we have a faculty discussing the case, and we thought that this time we'll bring more on management issues that we should handle this time. So I'll present a typical case that you will see very often in your clinic, and these are the kind of problems that you will say day in and day out in your clinics. So 23-year-old young man who was seen 3 years back with hypertension of about 1 year duration. He had also noticed froth in his urine for about 6 months and had seen a physician who got a urine examination done and saw there was protein 2+. There wasn't any sediment, no RBCs, few WBCs. Serum creatinine was 1.5 milligrams per deciliter, which corresponded to an eGFR of about 68 ml per minute. And urine protein creatinine ratio was 1.8 grams per gram of creatinine. An ultrasound was done, and at that point of time, they found that there was a right small kidneys. It was 7 centimeters with irregular margins, increased echoes. Left kidney was also slightly smallish, maybe 9 centimeters, irregular borders, and increased echoes.
Does anyone have any?
Mm-hmm. Okay. Yeah. Anyone would say what this patient could have as far as diagnosis is concerned? Any kind of ideas? What could be the possible causes of this patient having renal dysfunction, proteinuria, non-nephrotic proteinuria?
So can I take a crack at analyzing this case?
Yes. Today you are lucky that you have Dr. Vivekanand Jha to look at this and discuss this patient. Yeah, Vivek, you can go.
So this is a young male who presented primarily with hypertension. So that was the first presentation. And it is reasonable to suspect that hypertension making its appearance for the first time at the age of 22, because that is how old he would have been when the diagnosis was made, is likely to be a secondary hypertension. Now, we don't have any information about the severity of hypertension and whether he received treatment for it, was he treated or not, but be that as it may, he noticed some froth in urine for last 6 months, which is neither here nor there. I mean, froth is a relatively non-specific symptom, but if someone says froth in the urine, I take it that that person is indirectly trying to suggest that there is some proteinuria appearing at this point. So some degree of proteinuria, whether it is possible that this abnormality was present even before, but the patient did not notice it. So I don't think that I would give a lot of importance to the timing of it, but the finding is definitely notable. Then someone does a urine examination, and he is detected to have proteinuria, which basically confirms the clinical finding of froth in the urine. The urinary sediment is bland, and I'm guessing that all of these tests have been done now, which is 1 year later.
Yeah, no, he was seen 3 years back. He was 20 years of age when he was first time seen by that time. Yeah, and had.
So what I mean is that these tests were done at that time when he was first seen.
Yeah, he was first seen. He was seen first, and he came with these reports.
Yeah, he came with these reports, and when he was first seen, he already had hypertension for 1 year, right? So clearly the eGFR is reduced, 1.5 creatinine, eGFR 68. I suppose this is the CKD-EP equation.
Yes.
And you also see that he has some proteinuria, which is not nephrotic range, of course, but it is not insubstantial also. So it is severely increased protein excretion in the urine, right? Then comes the ultrasound. So in ultrasound, what you are seeing is very notable findings of one, asymmetric kidneys. So the right kidney is smaller than the left kidney by 2 centimeters. So we do know that for asymmetric shrinkage of a kidney, one needs to have the difference in size of more than 1 centimeters if the left kidney is smaller, and more than 1.5 centimeters if the right kidney is smaller. So it is 2 centimeters. So it is asymmetric contraction of kidneys. The left kidney is also smaller. And the second important finding is that the borders are irregular, right? So secondary hypertension, some proteinuria, asymmetrically contracted kidneys with irregular borders. So secondary hypertension with proteinuria, reduced EGFR, one would suspect either a renal parenchymal hypertension or a renovascular hypertension. The fact that he has significant degree of proteinuria tilts the diagnosis in favor of renal parenchymal hypertension. Small asymmetric kidneys can also be as a result of either renovascular disease or parenchymal disease. Irregular borders argue against a diagnosis of renovascular disease. Renal parenchymal disease is possible, and the nature of the disease that can give rise to irregular shrinkage of the kidneys is likely to be vesicular reflux, which is possible in this relatively young individual. So this is where we can possibly reach with this much of history.
Thank you, Vivek, for that. And I would also, since many of you are going to be exam-going students, so it's something that you should be confident in sort of looking at these kind of things, and in your mind go through this kind of a differential diagnosis that this is what is possible. It could be renovascular, it could be renoparenchymal, and the way Vivek discussed that from this kind of the information that is available, it's quite likely that this patient may have had a reflux. The medications which he had received was amlodipine 5 milligrams twice daily. He had also received soda.
Also to add at this point that there is a significant degree of proteinuria. One can also go ahead and say that likely this person might have a focal segmental glomerulosclerosis, secondary focal segmental glomerulosclerosis.
Right. So amlodipine 5 milligrams twice daily. He was on soda bicarb, and somebody had also added keto, add 1 tablet thrice daily, which doesn't surprise me. And he was told to stop non-vegetarian food, milk and dal, and multiple serum creatinine values he has had during these 3 years ranged from 1.3 milligrams per deciliter to 2.2 milligrams from various labs across. However, after this first initial proteinuria, he was seen by few nephrologists and physicians. The proteinuria was never quantified after this first episode of 1.8 grams. Serum bicarbonate, although he was on bicarbonate therapy, but never at bicarbonate level was tested. And obviously calcium, phosphorus, and parathyroid hormones were not evaluated during this illness at all. I will go straight. He came to me for second opinion, and I couldn't find any history of a urinary tract infection in the past or any other interventions, surgical interventions in early childhood. He denied any fevers and I didn't have a family relative or a mother to confirm whether he had had any fevers in the early childhood. He had lost about 5 kilograms of weight during the last 3 months. His blood pressure on the day I examined him was 140 by 90 millimeters of mercury. All peripheral pulses were, there wasn't any renal bruit. He had cardiomegaly, and other systemic examinations were normal. There were no cardiac murmurs, and fundus showed a grade 1 hypertensive changes. So Vivek, would you add anything else at this point of time, or you?
No, I think nothing really to add. It's notable that there is no past history of urinary tract infection, or as you say, early interventions in early childhood, because that might be an indicator. I would like to have asked him if there was any history of prolonged nocturnal enuresis or prolonged bedwetting as a child, or any
He
other.
denied that. He
Yeah,
denied that. He
that's
denied
all.
any
Yeah.
enuresis or any bedwetting. I think that's an important history, negative history, which is many times present in patients who have had either a reflux in their early childhood. Yes, I would agree with that.
Yeah.
And
So
the investigations suggested that his hemoglobin this time was 12.4. The total counts and platelets were reasonable. Urea was 56, creatinine was 1.9 milligrams per deciliter, and the EGFR now on CKD-EPI was 50 ml per minute. Bicarbonate, which I had got done, was 28 milliequivalents per liter. Sodium and potassium were normal. Parathyroid was 100 picograms. Vitamin D was 36. Urine protein creatinine ratio was 2.8 grams per gram of creatinine, and urine routine examination did not show anything in the sediment, and urine albuminuria was 3+. So I got a DMSS scan done because the differential diagnosis was on a reflux. And what you can see here on is a right small kidney with defects, irregular borders with defects. There is an upper polar scars here and almost gone. The right kidney is shrunken. The left kidney also shows irregular borders with maybe an upper polar and probably a lower polar scar as well. So, which probably confirmed that this patient, I did a uroflowmetry because Vivek had said that were there any bladder kind of defects, that uroflowmetry showed normal urine flow with no residual urine in this patient. So as Vivek had argued, my likely possibility was a chronic pyelonephritis secondary to a reflux nephropathy with secondary focal segmental glomerular sclerosis to explain this degree of proteinuria. Obviously, he has a GFR which has come down to about 50 ml now, starting from 68 the first time, and obviously has a chronic kidney disease. So when he came to me, I think the relatives had come along with, and they wanted to find out whether the medicines that he was receiving were appropriate. They also were very keen to find out, is this disease reversible and can it be cured? And what can we do to prevent the need for dialysis and transplantation? He's a young guy and there's a many years to live for. And the progressive decline in kidney function would lead to need for dialysis and transplantation. And the questions were very relevant, that could we do anything to prevent or at least delay the need for dialysis, and what would be the long-term prognosis of this patient? And I think these were the questions, and I thought that I will ask Vivek to maybe take these questions one by one, and in addition, add other dimensions to the management of such a patient who is 23 years of age and comes. And this would not be something which will be an uncommon. It's a fairly common presentation. In your clinics, you will see this very often. And as a nephrologist, you will get patients who will come for second opinions to you and would want to know the answers to some of these questions. So Vivek, would you be?
Yeah, thank you, sir. So look, I think the diagnosis is now clear that most likely he has a vesicular reflux, and the ultrasound hasn't shown any persistent dilatation of ureter or the pelvic calyceal system. So it is likely that the reflux has disappeared. It may not have, but it might have disappeared also, which is not unusual at all in this situation. There is no history of any recurrent urinary tract infection, because that is another consideration which can impact on his treatment. Now, so far as the medication history is concerned, he is receiving antihypertensive agents. He is getting soda bicarbonate. And you said he was getting some keto analogs
Keto
also.
analogs. Yes.
So this is
Yes.
what I saw
Yeah.
from our
This is what he was.
randomized.
Yeah.
Yeah.
This is what he was getting.
So what is his current blood pressure, sir?
His blood 140 by 90 millimeters of mercury on the day when I saw him.
Yeah, so I would want to control his blood pressure even better, given the fact that he's relatively young, and we have data from sprint trial and other trials that good control of blood, hypertension is protective so far as cardiovascular outcomes are concerned. And given his age, even at his age, even if he had nothing else, one would expect that the normal blood pressure will be lower than this. So I would try to get his blood pressure further down to 120/80 or lower, provided he doesn't develop any symptoms. Second is I would make sure that he has a healthy body weight. So I don't know what is his weight. So depending on his height, if he's overweight, then to reduce weight. The third is increase in physical activity, making sure that he does the regular exercise as recommended, at least 30 minutes, 30 to 40 minutes, at least 5 days every week. Fourth is in terms of his diet, I would caution him on over restriction of his diet. So I wouldn't want him to stop this non-vegetarian food, milk, dal altogether. Of course, the dietary restriction should be as such that he takes about 0.8 grams protein per kilo body weight per day. And our studies have shown that most of even healthy, normal Indians do not take protein more than this, even in our usual diet. So my practice is to ask the person what are his normal dietary habits, and in accepting the rare situation where someone will say that they eat a non-vegetarian food or meat every day, which I have really not come across. I wouldn't ask them to restrict their diet or protein intake of their diet. That's number one. Second is there is plenty of data available to show that liberal intakes of fruit and vegetable is essential. So that is something which I would encourage him to start. Because rather than giving external sodium bicarbonate, for which there is no indication in this patient, by the way, because this serum bicarbonate you said was 28.
28.
So there is no indication for giving exogenous soda bicarb, but still we should increase the intake of fruits and vegetables. One is that it is alkaline, so it will give him some bicarbonate, of course. But in general, the diet rich in food and vegetable has been shown to be nephroprotective and cardioprotective also in patients with chronic kidney disease. So I would spend actually a fair amount of time in the first few meetings with him in making sure that we optimize his non-pharmacological therapy, which is important. Then counseling about his lifestyle is also important. No smoking, giving up smoking if he's a smoker. If he takes alcohol, then obviously moderation of alcohol intake. And finally, to counsel him that he should go about with his normal activities, as he wishes to, and he shouldn't restrict them because he has some kidney disease, because that also will have a long-term impact not only on his physical health but also on his mental health. So appropriate rehabilitation is important. Now, since again this is a young individual, I'm quite hopeful that this person is aware, wants to know about his kidney disease, not only the family, but he also wants to know. So it will be important to explain that these diseases are potentially progressive, and but that we can substantially arrest the progression of the disease. I think so, so that there is a realistic expectation of the prognosis. That's important. And what will be the rate of progression and how much can we arrest it is not, it's not possible to predict in just a few initial visits, but it all depends on his adherence to many of these measures that he will be advised to. And obviously everyone responds somewhat differently. We don't know how much of renal parenchyma is left. Now, that was about the non-pharmacological therapy. Now, in terms of the pharmacological therapy, I would start him definitely on an angiotensin blocking agent. So angiotensin receptor inhibitor or angiotensin ACE inhibitor or angiotensin receptor blocker. So these agents I would definitely start in terms of the preferred agents for control of his blood pressure. I realize that monotherapy is unlikely or may not be able to control his blood pressure, in which case we can add other agents for control of blood pressure as well. So I would say, these are the agents. Of course, I would stop the keto analog in this person. His vitamin D levels were low, so I would replace vitamin D as the native form of vitamin D, not the activated vitamin D at this stage. Can you just go to the investigation slide? I'm not sure if I'm missing anything else. There is cardiomegaly, right? You have
yes.
There is cardiomegaly. So that's interesting. So one would like to know more about his cardiomegaly. What is the cause of his cardiomegaly? So I don't know whether he was investigated from that point of view, if an electrocardiogram was done, and if he underwent an echo. But I would definitely want those investigations.
Yes, he had an echo done by a physician earlier, and that had shown left ventricular hypertrophy. So obviously this hypertension remained probably uncontrolled for a reasonable period of time during these last 3 years before he came to me. And his echocardiogram did show left ventricular hypertrophy, as well as the ECG confirmed that there was left ventricular hypertrophy.
But with left ventricular hypertrophy alone, one wouldn't expect to see cardiomegaly. So that is why I was.
But this was a physical kind of a feeling that this was cardiomegaly. So
yeah.
I think Vivek, I think you made a very valid point that you need to also spend a lot of time on the non-pharmacological therapy, because as physicians we spend reasonable amount of time and as well as effort in modifying drugs, adding or deleting or whatever we might do. But I think spending time on the nutrition, this is a young man who has another 50 years to look forward to. And with this chronic kidney disease, obviously many of these patients remain under the constant fear, not only of the nutritionists to whom they go and the nephrologists and the physicians who will cut down their protein intake significantly, and they become malnourished. And I think malnutrition is a big issue in patients of chronic kidney disease. And I think you did an extremely good job in telling that this is an area which physicians must, and as nephrologists, you must spend time on these patients before you look at the pharmacological therapy. And these are all extremely important in this young man. And I think that's very important. So please keep it in mind all the time whenever you have this. And in the exam as well, this is going to be extremely important.
And one point which I forgot was to talk about salt restriction in the diet. So obviously we should make it a point to emphasize salt restriction. And in salt restriction, while we ask the patient to restrict their salt, in the same breath we should point out that it doesn't mean total elimination of salt from the diet. And also many people, unless you explain to them very clearly, they will go back with the impression that they can stop taking the normal salt that is available, the table salt, and replace it with rock salt or something like that, which will be totally counterproductive. So we should take the time to explain that no, rock salt is also not acceptable. People also.
Yeah, you carry on. I'll ask you another question on this while we are here. You carry on.
I was also going to say that people are also not aware that any processed food item contains a lot of salt, which includes breads, for example, the breads that we eat, or the cookies, even the sweetened cookies, they are full of salt. So all that needs to be explained to our patient, relatively young individual. It is possible that he goes out and perhaps on occasion will be tempted to consume these items. So this is not to say that he can never take these, but at least he should be made aware that regular consumption of these items will negate the salt restriction that he will undertake in his in the food that he takes at home.
Yeah, Vivek, I wanted one point to be maybe made still important point to be emphasized again and maybe over again stated. And that's, you talked about the fruits and the vegetables in these patients. There is always a fear amongst the nephrologists as well of that the potassium in patients with chronic kidney disease creates, or they are always worried about the potassium, and therefore many of them would restrict the use of these. And the recent publications suggesting that actually oral intake of these vegetables and hasn't in fact affected either the mortality nor affects the serum potassium levels. So would you want to emphasize it again that this is something which the nephrologist shouldn't be worried too much about, and everybody doesn't develop hyperkalemia in with these kind of diets?
No, absolutely. You are exactly right that it has been shown now in several studies that the serum, that a diet rich in fruits and vegetables does not increase serum potassium in a vast majority of people with chronic kidney disease also. But obviously, this is not again a blanket statement. We should look at patients. Doing a serum potassium as a part of initial workup is universal. So you would have seen serum potassium. And if you see just one odd value of high serum potassium, don't immediately assume that the patient has hyperkalemia, because there are a number of reasons why the serum potassium, single serum potassium value might indicate either a wrong measurement or might be temporary because of some reason or the other. The most common cause of hyperkalemia is improper sample collection or processing. So we should always repeat the serum potassium, because just with that, you would be depriving a patient of a significant part of the right kind of treatment that the patient should receive. So that's really very important to emphasize at this stage. And also, if the serum creatinine is 1.9, eGFR 50, it's very unlikely that this patient will develop life-threatening hyperkalemia. Life-threatening hyperkalemia is, of course, much more likely in people with more advanced kidney disease, in stage 5 chronic kidney disease, etc. And even if they develop hyperkalemia, for the sake of an argument, rather than stop their intake of fruits and vegetables, we can take measures to correct hyperkalemia or to manage hyperkalemia. And there are simple ways of managing hyperkalemia, one of which is addition of diuretics. Diuretics are grossly underused as a management for management of hyperkalemia. So even when you see a high serum potassium, you will reflexively prescribe a potassium binding resin, which is relatively inefficient for correction of hyperkalemia, correction of pre-existing hyperkalemia. So in case you're worried about it, I would say use other modalities of treatment, including use of diuretics.
Yeah, I would again emphasize, very underutilized for treatment of hyperkalemia. Somehow, even nephrologists are not using diuretics for control of chronic hyperkalemia in small number of patients where hyperkalemia is. I find everyday patients where just adding a diuretic probably will take care of the hyperkalemia and allows you to use other proper appropriate drugs, especially ACE and ARBs in the context of chronic kidney disease, which Vivek was talking about. And that addition of a diuretic will help you to appropriately and optimally utilize these drugs, which is extremely important for long-term decrease in progression of kidney disease and their long-term outcomes. So Vivek, what else would you do for this patient as far as ARBs are concerned? Now, there is again a concern that these drugs are, what would be your method of optimizing the dose of angiotensin receptor blockers or ACE inhibitors in these kind of patients? So how would you sort of start the dose of these dosages? What would you prefer? And ACE, this is commonly asked, the nephrologist should usually be answering these questions. And when you talk to the physicians, these are common questions which are asked, but I think nephrologists should know how to answer these questions. So how would you start an ACE or an ARB? Would you prefer ACE inhibitor, ARBs? Any choices that you would make? And how do you make that kind of choice?
I am not aware of any clear criteria on which to choose one or the other. One reason not to use ACE inhibitors would be if a patient develops cough related to ACE inhibitors or any other complication, but that we will know only if after we have started this agent. The second is, of course, cost. The cost of therapy could be important for some people, although with the widespread availability of generic agents in Indian market, cost is generally not that much of a concern in the Indian market. But I would be curious if you have any other rule of thumb for deciding between choosing ACE inhibitor or angiotensin receptor blocker. But I would really go by the availability and patient preference.
Yeah,
cost.
the only choice I make if I'm using is a longer acting ACE or an ARB, like I would use if I'm using a angiotensin receptor blocker, then telmisartan and olmesartan would be better than using, say, losartan or something like that. So I choose probably a longer acting one, which has to be taken probably once or maybe at least not more often. And same would be as far as ACE is concerned. So I use either a ramipril, which is again a long acting one, or a lisinopril, may be given twice rather than now. These are fortunately, as you said, many of these drugs are available in the Indian pharmaceutical sort of market, and they are not that expensive also in comparison to what is available in the Western world. So predominantly these, but if there is somebody who is already on an ACE or an ARB, and unless there is a specific reason to change, sometimes I do find patients are on 25 milligrams of losartan, one tablet, and then I feel that this is a drug which acts only for 6 to 8 hours. So taking it once may not be enough. I would either divide it. If the dose is appropriate, then I would divide it into two and say that you can take 12.5 or 25 milligrams twice rather than once. So optimization of the dosages. And I feel that what most nephrologists don't do is that you need to optimize the dosages not only for control of blood pressure, but there is another marker or a biomarker which we somehow are not targeting, and that's proteinuria, degree of proteinuria. And decreasing albuminuria, proteinuria is an important target which we should decrease. We should optimize these drugs for. And I think many patients remain on smaller doses because their blood pressures are controlled. But if you keep on increasing their ACE or ARBs, trying to decrease albuminuria, you will be able to use optimal doses to reduce at least by 50%. That is what guidelines suggest, that you should want the proteinuria, if not go from overt albuminuria to an microalbuminuria or moderately increased albuminuria, but at least decrease it by about 50%. So what's your take on, would you want to target albuminuria? Somehow nephrologists don't do it.
No, absolutely. All your points are extremely important and well made. Preferably use the longer acting drug, whichever one it is, whether it is angiotensin receptor blocker or ACE inhibitor. And second is to push the dose up, to the maximum tolerated dose. And maximum tolerated dose in terms of blood pressure, so that they don't become hypotensive. Of course, serum potassium monitoring is useful. We should do that. When I would start with a relatively small dose, just to make sure that there is no first dose effect. Some patients are intolerant, and so they may develop hypotension. And if the patient tolerates it, I would rapidly scale it up. So every 3 to 7 days, I would increase the dose, just in the manner that you are suggesting, Professor Kher. And even after the blood pressure is controlled within the target range, and if the patient continues to tolerate it, I would still increase the dose to a level which brings the proteinuria down, just like you are saying, by more than 50%, and if possible, less than 1 gram a day.
Yes, I thought that that was one. Vivek, you have, suppose this
Sorry,
patient was a,
just one point
yeah,
on that. So
yeah,
one of the reasons proteinuria may not get controlled even if a person is taking ACE inhibitors and angiotensin receptor blockers is if they don't restrict their salt. This has been well demonstrated that high salt intake counteracts the antiproteinuric effect of angiotensin converting enzyme inhibitors and angiotensin receptor blockers. So if a patient is not responding, do ask the question, do make sure that the patient is compliant with low salt diet, including including the fact that they are avoiding consumption of those packaged foods, which inadvertently might be contributing to the increased salt intake. I thought that was also a point which we should make.
extremely important point, and I think a very, very important point which must always be kept in mind. And I think you should, especially Indian snacking, the haldirams and the other foods, and these days now even processed food, pizzas and all do come home also. And even many elderly people, since children are bringing it home, many elderly people are also consuming it. So it's important to go into nitty-gritties of what food they are eating and what is the quantum of salt they are consuming. And that's extremely important. And adding a diuretic to an ACE or an angiotensin receptor blocker would increase or enhance the potential actions of this. And that's physiologically also appropriate. Actually, diuretics increase the excretion of salt that will activate angiotensin receptor, and then angiotensin receptor blocker or an ACE inhibitor will with the activated angiotensin system will decrease the blood pressure and also help in reducing proteinuria and these things. And as Vivek was saying, that your target for blood pressure in these kind of patients should be something, and especially a young patient like this would be 120/80 and less, and not above that. And I think that's important, especially for the long-term good outcomes that one would want this patient to have. Vivek, one point which again bothers many nephrologists, and I find it very commonly amongst the practicing nephrologists, is that they are using these drugs. There is no acute event, just the real progression of kidney disease occurs at a stage. Maybe now this is a person who is in stage 3 and he's, say, the creatinine goes up to around 2.5, 3, and they suddenly stop ACE and ARBs. And if it was volume depletion or there was an acute factor or so, I can understand it, and then probably restarting these angiotensin receptor blockers may be okay. But they completely stop these, thinking that these drugs now become toxic drugs. So what's your take on this?
Right. So I would need a very strong reason to stop these agents, because there are now compelling data from randomized clinical trials, from observational studies, etc., to suggest that these agents continue to retain their cardiovascular benefits even at very low levels of GFR. So I'm not going to suggest that they should never be stopped, but I think I have to be persuaded to stop these agents, and I wouldn't stop them just because the GFR has declined from a previous level, which will happen. And I would say that this person's GFR might have declined even faster had this person not been on an ACE inhibitor or angiotensin receptor blocker. Now, the point that one needs to make is that even in a patient on dialysis, residual kidney function is one of the strongest, or if not the strongest, predictor of long-term survival. And there is data, especially in patients on peritoneal dialysis, that continuing ACE inhibitor or angiotensin receptor blocker will help with preservation of residual kidney function in these patients also. So there are a number of reasons, some supported by clinical data, Others, very, very strong mechanistic reasons to 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 ensure that we need to continue to treat these patients with these agents. Of course, not unless there is some compelling reason to stop them.
Yeah, I would agree that I keep on emphasizing that you should have very compelling reasons to stop this. At least 50 to 60% of my patients on dialysis are on ACE and ARBs. So they should be continued for their cardiovascular benefits. And even if you have to stop it for an acute reason, there may be a volume depletion or a sudden acute on chronic kidney disease, which may have happened because of either volume, fever, or some acute illnesses, which there are sick day rules for use of angiotensin receptor blockers. But you should not forget to restart these drugs immediately after the acute event has passed by. So I think it's extremely important. And I think that's why I wanted Vivek to sort of emphasize that these drugs are essential drugs, much more potent than the trust that many physicians and nephrologists put on keto analogs and many other drugs which are commonly found in our patients' prescriptions these days. So there is evidence based to the use of ACE and ARBs even in advanced stages of kidney disease. And I think that's been very well emphasized by Vivek. So I think, Vivek, that's very well done as far as the... Yes. Yeah, Vivek, go ahead.
Just one point which I've forgotten in terms of pharmacological therapy. One point which I have forgotten in terms of pharmacological therapy is the use of this patient on a statin based on the results of
Sharp
study. Yeah, it's been shown to especially in this patient, again, young patient, there is already a cardiovascular left ventricular hypertrophy, as you showed. This patient
Can we mute yourself if you're not speaking? Yeah, Vivek. Vivek, I think we lost. Hello. Vivek? Puneet, have we lost Vivek, I guess?
So seems to be there.
Well, Vivek, can you hear me? Puneet?
So I think connection is lost, sir.
My connection, you can hear me?
Yes, sir, you were there, sir. Dr. Vivek Jha, sir.
Yeah, I think maybe he is disconnected.
Yes, sir.
I'm back.
Yeah, you're back. Okay. Yeah, you were saying that the SHARP study had shown that statins must be given to patients with.
Yeah, so I would start this patient on a statin as well.
Yes, definitely. And I think there is enough evidence that should be done, not only to reduce the outcomes, improve the outcomes in this patient, especially the commonest cause of death in patients of chronic kidney disease is cardiovascular disease. And I think lowering lipids definitely will improve the outcomes, cardiovascular outcomes in this group of patients. So that's one. Vivek, now a lot of other newer drugs have also started preparing, and they are for nephrologists. After the ACE and ARBs, there hadn't been any new drugs which one could use in slowing down the progression of chronic kidney disease or decreasing proteinuria. You didn't have another drug by which you could say, if you're not sufficiently able to decrease this or slowing down the kidney function. Now, SGLT2 inhibitors have come as another new drugs. And then we have finerenone, the mineralocorticoid receptor antagonists, the non-steroidal ones, which are also available now, and the 2 randomized trials, and now the real-world data also suggesting that these are extremely useful drugs. So where would you use these drugs, and how about this patient? How would you pitch in these drugs in this kind of a patient? Or do you think that there is a role for this kind of drugs in this patient?
Yeah, very interesting question. I think it's good that we have this dilemma in front of us, which means that we have choices which we can offer to our patient. And so we are discussing whether to utilize those choices or not, So this is very important. So of the two options that you mentioned, the SGLT2 inhibitor one seems to be much more relevant to this situation. Because based on the DAPA-CKD trial, we have now compelling evidence and also FDA approval from some other regulatory agencies for use of SGLT2 inhibitors, especially dapagliflozin, because that is the one with which there is evidence. And now the EMPA kidney trial is also expected to perhaps complete recruitment this year. And so we'll have results of the EMPA kidney study also. So according to the DAPA-CKD trial, this patient fits very well into the group of patients who were enrolled in the DAPA-CKD study and were found to be positively or beneficially impacted by the use of dapagliflozin. So after this patient has been appropriately treated with ACE inhibitors, angiotensin receptor blockers, I would also consider potentially using SGLT2 inhibitors, in particular dapagliflozin in this particular patient, given the fact that he also has significant degree of proteinuria. So both of them are good reasons for us to consider the use of this particular agent. Now, finerenone, so far as the evidence is concerned, we don't have evidence of benefit with the use of finerenone in non-diabetic chronic kidney disease. So we'll have to wait until more evidence is generated before we can make a recommendation for its use in non-diabetic population.
Yes, but Vivek, now if you were to use, if this patient came to you as a patient and he is on amlodipine, now you have SGLT2 inhibitors also available with you, and you have an ACE and ARB also available with you. So what drug would you use first, or would you use these drugs or start them together? Or would you want to individualize them?
Yeah, this is a very interesting approach. So I would definitely start with an ACE on ARB. I won't use both of them together for obvious reasons. There is evidence of harm with combination therapy. So I would use either one of them, but I would increase the dose to the maximum tolerated, as you said. And this time I'll add SGLT2 inhibitor after that. Now, there is a new approach which suggests using drugs in fixed dose combinations. So a fixed dose combination of angiotensin receptor blocker or angiotensin converting enzyme inhibitor and an SGLT2 inhibitor. I think the rationale for using fixed dose combinations, especially low dose fixed dose combinations. So low dose of an individual agent. That is a slightly different approach from the one that we have been discussing so far. And that is proposed to be used as individual therapy in patients with uncomplicated hypertension. New fixed dose or polypills have been proposed for chronic kidney disease, for gout, cardiovascular disease, which combine not only antihypertensive agents, but also a statin and aspirin, etc. To make sure that these patients will take these agents to improve compliance and to reduce the risk of side effects. Because you use the relatively low dose of individual agent in those situations. Use even 3 or 4 antihypertensive agents all in combination, but low dose of each of those. But right now, we don't have evidence for benefit from that approach in our population with chronic kidney disease, or whether due to diabetes or non-diabetic kidney disease. So, we should definitely test these in future studies. But until that happens, I would use ACE inhibitor or angiotensin receptor blocker, following it up with SGLT2 inhibitor. And if the blood pressure doesn't get controlled, then of course add other agents in such a patient.
Yes, usually you will need 2 or 3 antihypertensive drugs to control blood pressure in patients of chronic kidney disease. So ACE and ARBs should be the backbone of the antihypertensive therapy, unless there is a specific contraindication to use this drug, which in my practice would be rare. I mean, you have alternatives. If somebody is not tolerating ACE inhibitor, then you will have an angiotensin receptor blocker. So it's been very rare that you will have a patient in whom you may not be able to give ACE and ARBs. So ACE and ARBs have formed the backbone of treatment of our patients for last 20 years or so, and therefore we are more used to it. So I also use ACE and ARBs as the fundamental drugs first. And then now with the availability of SGLT2 inhibitors, you have another evidence-based molecule, especially dapagliflozin in patients who are non-diabetic, to use this as a drug for antiproteinuria and slowing down the progression of kidney disease. So that's another approach. And usually you can use these drugs together. Obviously, as Vivek suggested, that I would not use them together simultaneously, start it simultaneously, because there is a first use effect, and sometimes the decrease in the GFR may be too significant. So I would start with one drug and then add an SGLT2 inhibitor later in these patients. However, if there is a problem with an ACE or an ARB, then you could start with an SGLT2 inhibitor and add. And combined use of SGLT2 inhibitors also decreases the degree of hyperkalemia somehow in these patients, because hyperkalemia is not seen with SGLT2 inhibitors in these patients. So now, I don't think this question needs to be discussed, whether this is not a reversible condition, usually a progressive, and Vivek made it clear, and this is something which is a progressive disorder, cannot be cured. But Vivek, one point on, because this is a common question, which is that can we prevent the need for dialysis or transplantation with these therapies, and what is the kind of things that we can do in addition to see that if we may not be able to prevent it in this young man, but at least delay the need for dialysis and transplantation. Comments on that?
Yeah, I think we did discuss most of those possible interventions that we can suggest, which included non-pharmacological interventions followed by pharmacological interventions to delay the need for dialysis and transplantation. That's what I would say. But do you have any specific?
No. I was thinking that many people somehow. I believe that many physicians and nephrologists also have very little trust, although these drugs have not been available. Although ACE and ARBs have been available for 20 years, but the usage has been sort of not optimal because of the concerns for unusual concerns, and sort of a very quick knee-jerk kind of reaction to stop these useful drugs. And otherwise, I have had patients who've been on these drugs and have done extremely well, and one is successful in sort of delaying the need for transplantation in younger people by many years. These patients may not require transplantation till 20-25 years. You might be able to see many of these patients if they follow their blood pressures well, they're following with you. Many of these patients you may transplant. You had seen them early in 23 years, and you might be able to 10-15 years or 20 years also, you might be able. And with the newer drugs available now, it's quite possible that we should be looking forward to delaying the need for transplantation or dialysis. And in some patients, if we catch them early, maybe probably prevent it.
Yeah, absolutely. And it's a pity that people take the easier option of stopping these agents, despite the fact that stopping the, I mean, immediately you will not find anything, or you will not, or the patient will not see anything. But in the long term, there is real world data from Dr. Mani's studies in
Yes.
Rural settings in Tamil Nadu, where he has shown that people could prevent the development of more advanced chronic kidney disease with the use of I think he used to give them enalapril. Initially
Yes.
he used to use other agents, but later on he started using ACE inhibitors, and he would use enalapril. So that is something which is important.
Yeah, I have seen him using 120 milligrams of enalapril.
Correct. Absolutely.
Yes.
Yeah.
He would keep on going up and up and up. And I've seen some of his patients who would really ask, sir, namak nahi khaya, bahut saalon se nahi dekha bilkul. So he would really ensure that the point you made, that salt restriction is an extremely important element of treatment in combination with AS and ARBs, because they become effective if you have salt restriction. If you continue to eat salts, their effects get dwindled.
Yeah.
So it's important to do that. And I've seen some of his patients, and he uses fairly large doses and has been able to really show that in his patients, he was able to prevent development of end-stage kidney disease.
That's exactly right. And look, people who have proteinuric chronic kidney disease, I think once we have gone as high as we can with the angiotensin receptor blocker, etc., if the proteinuria is still significant, then at least in the Western countries, the use of mineralocorticoid receptor antagonists is also considered. For example, spironolactone or eplerenone. These are steroidal MRAs. We are not talking of, and that is not for not necessarily. We don't have data that suggests that they offer long-term protection, but they are used for blood pressure control and reduction of proteinuria. And there is a suggestion that use of non-dihydropyridine calcium channel blockers should be preferred over dihydropyridine calcium channel blockers like amlodipine or nifedipine. So the non-dihydropyridine ones are verapamil and diltiazem, etc. But of course, they are less potent so far as blood pressure reduction is concerned.
Yes, I agree. Tom Hostetter, a long time back, he gave a talk when I was in Lucknow, and he had done some real good experimental work on mineralocorticoid receptor antagonists in the rats, and shown that the progression of kidney disease, at least mechanistically, they had been able to demonstrate that they were able to slow down, not only reduce proteinuria, but even slow down, although there's no good human data. And as Vivek said that, but yes, reduction of albuminuria is a target that nephrologists should ask for, should be continuously monitoring. And in fact, these days now, outside nephrologists have started talking of that cardiologists don't target albuminuria in their heart failure patients, in their cardiac patients, because that's many of the drugs that they are using these days will target, and they should optimize the dosages of these drugs, also looking at what happens to albuminuria, because albuminuria is a cardiovascular biomarker, a death marker for cardiovascular death, in addition to being a marker for progressive kidney disease.
No, absolutely. I think one more point which I would like to emphasize is the technique of blood pressure measurement. Given the fact that we often focus on treatment of blood pressure, we don't give enough emphasis to correct measurement of blood pressure. And nowadays, particularly after the SPRINT trial, it is not appropriate for us to continue measuring blood pressure using the old method of single blood pressure measurement in the office, etc. So 3 blood pressure measurements in office if possible, without the presence of the physician in the office, by these digital recordings, oscillometric blood pressure instruments that measure blood pressure and take 3 readings and give you the average of those readings. That's really important. And we should increasingly be using office blood pressure recordings for management less and less, and depend more on home blood pressure recordings. And if possible, ambulatory blood pressure, the ambulatory blood pressure one would not need very much, but I would recommend in this 23-year-old person that they should get a home blood pressure device and monitor their blood pressure at home. And the right way of doing it is whenever they have their scheduled visit, to do this 2-3 days consecutively just before coming, twice a day, and bringing a record of that to the office of the physician, to supplement that record with office blood pressure, also again taken in a standardized format, to guide antihypertensive therapy.
Yes, no doubt about that. And this patient, I had advised to buy a blood pressure monitor. We helped him to get one. Fortunately, Sun Pharma, along with MicroLife, is tied up and supplying these blood pressure monitors at half the price. So many of my patients are able to buy this watch BP, home watch BP, which monitors blood pressure 3 times. And if they can be taught to take their blood pressures and bring their charts with them while they come for a visit, that has helped in effective control of blood pressure in many of my patients. And it only needs to be told, and you get surprised actually how many patients are willing to buy and do this for themselves. And especially in this young man, I would agree with Vivek that this is an extremely important step in controlling, and he's fortunately bought it, and he's come twice to me with the blood pressure, and his blood pressure on telmisartan, he continues to use amlodipine, and his blood pressures are 120 to around 70 or so with these over the last 6 months or so. So that's been happening, and I think that that's extremely important. And I think every physician must tell their patients to buy these, and many of them are more than willing to buy this and use this. Anything else, Vivek, you would want? I think probably we covered most. Today, I wanted to predominantly talk more about the management of these patients, and especially look at the nuances of some of these newer drugs which are available with us, and also talk about that the sort of knee-jerk reaction of stopping many of these good evidence-based medicines is important to be highlighted, so that we continue to use them optimally and appropriately in our patients for maximal optimal outcomes in these patients. And so I thought that that's what the emphasis today was, and I'm very glad that Vivek, despite doing a class last time, agreed to be part of this, and I'm extremely happy that it is gone. I'm sure you would have learned the small little things that become extremely important and usually are neglected many times, and many of us may not give that kind of importance to, but it's usually all the things taken together that's going to produce the better effects and lasting effects in our patients. And I think non-pharmacological treatments as well, exercise, alcohol, smoking, all these need to be taken into account. Salt intake, diet, in addition to the pharmacological therapy, and exclude the pill burden. Vivek indirectly brought that by using these polypills as such, but pill burden is an important thing that many of our patients, and you should always look at the number of drugs that your patient is taking and see if you can exclude an unnecessary drug which the patient may have been prescribed, and sometimes you may have also overlooked a drug previously and tried to see every time on the prescription, can you exclude a drug, because the number of drugs a patient is taking is likely to forget an important drug and might be taking something like keto ad or any of these drugs which many of these patients are prescribed.
Yeah, this is important. I think the point about drug interaction is an important one, and you should look at if a blood pressure is if a person is coming to you with uncontrolled blood pressure. One of the things that you should do, rather than just reflexively adding just another drug, to look at the entire drug list of this person. In addition to, for example, compliance with salt intake, see if they are taking some other drug which can interfere with antihypertensive effect. And I'm sure many times we have been surprised if you start anti-tubercular treatment to a patient on dihydropyridine calcium channel blocker like amlodipine, suddenly the blood pressure will go high because rifampicin increases the metabolism of these agents, and so their antihypertensive effect disappears. So do have a list, and do have a look at the list of the other drugs that the patients are on. Finally, we were talking about home blood pressure. Home blood pressure monitoring also allows you to identify one form of hypertension, which we often miss. We talk quite often about white coat hypertension, in which a person has high blood pressure in a doctor office, but normal blood pressure outside. But there is another type of hypertension called masked hypertension. And masked hypertension is, you identify masked hypertension when the in-office blood pressure readings are normal, but home blood pressure readings are high. And masked hypertension is particularly common in patients with chronic kidney disease, and that can be detected only if a person regularly does home blood pressure monitoring. Masked hypertension has been shown to be associated with worse long-term outcomes.
Yeah, I think, do people have any questions? If you have any questions, either raise your hand or let's see, there is something somebody has written. Renal artery stenosis possible as kidneys are disproportionate proteinuric. Asymptomatic kidneys with irregular young hypertensive with underlying reflux nephropathy. This is somebody who's put in the chat. We discussed these, so I don't think there's anything in this to discuss, but any other questions if anyone has? Anyone has any questions? We can.
And just one last point is that we shouldn't forget about the potential use of diuretics. You have repeatedly brought in the use of diuretics in terms of their additional benefits. For example, control of hyperkalemia and better antiproteinuric effects of ACE inhibitors, angiotensin receptor blockers. But they're good antihypertensive agents as well. So ACE are, if you are going to use them, then the next agent after SGLT2 inhibitors, which have only modest antihypertensive effect, should be a diuretic also in such patients. And you can use easily thiazide type diuretic.
Yeah, I think, and Rajiv Agarwal has recently shown that these drugs like clothalidone, especially even in advanced renal disease, where we considered these diuretics to be ineffective actually. And he has shown in stage 3, stage 4 chronic kidney disease, and recent New England Journal paper in which he showed that these drugs are effective antihypertensive drugs and they are very effective. So this very apt point that diuretics should be used in patients with chronic kidney disease, and they would help not only control blood pressure, proteinuria, as well as improve the efficacy of many of our drugs which we're using, especially ACE and ARBs. Right. So I think Vivek, I don't think there's anything. I think it's okay.
They are exhausted.
Thank you. Yes. Thank you very much. I think it was very nice. maybe we would, Puneet, ask them
sir.
that is there anything else also maybe they would want to
Surely, sir.
discuss. We would be very keen to have an input of theirs as well as to how are they sort of liking this kind of a discussion. I feel that it predominantly the purpose of this is to bring in analytical abilities of looking at the case as it is presented, not from the perspective of what may happen, but as it is presented, and then look at some of the predominant aim this time today was not for diagnostic purpose, but more for therapeutic and management purposes. And I think I'm very glad that Vivek joined me, and it was extremely useful to sort of look at how we would see the impact of these drugs overall in patients. Thank you. Thank you,
Definitely,
Vivek.
sir. There was a double bonanza.
Thank you.
with you and Dr.
Thank you.
Rao.
Thank you.
sir.
Thank you, Vivek.
Thank you.
Okay. Bye-bye. Good night.